Okay, so another MLA condition, so we're moving on to tremor. So we think of tremor as a rhythmic oscillatory movement of different velocities. So you can have a fast tremor or a slow tremor, and it should be involuntary. Although some people can try and distract themselves, you can't prevent a tremor. It usually affects the limbs, but it can also affect your midsection, it can affect your head, your chin, your tongue, rarely. We all have a tremor. We all have a tremor to some degree, and we call that a physiological tremor. And that gets worse when we're cold. It gets worse when you're anxious. If you're in a near miss when you're driving the car, you will shake, and that is physiological. The other thing is that if you drink a lot of coffee or tea, you can get worsening tremor, and it can also get worsening tremor with certain medications. Salbutamol is the obvious one. Medically, we like to define tremors as action tremors or resting tremors, but there are some tremors that only occur on certain postures. And the first tremor we come to is essential tremor. So this is a pure tremor. It is just tremor, and there is no other sort of clinical feature associated with it. We used to call it benign tremor, but for some people it's very severe, so we don't call it that anymore because it can cause distress. It's an action tremor, so people classically describe, when they're holding cutlery, their peas are falling off their spoon. If they're holding a cup, it wobbles on their way to their mouth. And the joke always is that if a man has an essential tremor and he's sent to buy a round of drinks, he buys pints, but everybody gets a half because he spilled half of it on the way back. You can also get a head feature with this, which we call titubation. So it can be yes, yes with a nod, no, no with a shake, or a bit of a mixture. And people ease the tremor by resting their hands down. This is the tremor that can be eased by alcohol, which is why we ask it in the history. It's often familial, so lots of people in the family may have it, and it's quite a rapid, fast tremor. Generally, when we give a clinical diagnosis, it's reassurance. People are always worried they have Parkinson's disease, but clinically it's usually quite easy to ascertain the difference. They would have no other features that would suggest Parkinsonism, no other non-motor features, and the examination would generally be enough. And once you reassure people, for some folks that's enough. If it's particularly problematic, you can try some medication. Beta blockers, propranolol, that's generally the most effective with the fewest side effects. Some people can't take that because of asthma or a slow heart rate. So we can try other things like topiramate, for example, or primidone. I don't like primidone because it's addictive and sedating. And that's the other thing about essential tremor. You always need to balance the expected benefit with the risks. And a lot of people would prefer just to have the tremor and be reassured rather than take the side effects. It can get worse with age. And there are advanced therapies now, such as deep brain stimulation and sort of targeted ultrasound therapy, which can create a lesion, but they're very advanced and only for people with very severe tremor. And just to mention other forms of tremor, so there's dystonic tremor, and that's so when we talked about dystonia as abnormal posturing, that's a sort of jerky form of tremor with other forms of dystonia. Usually that's a tremor that doesn't respond to medication. Sometimes you can have a bit of difficulty distinguishing between essential and dystonic tremor. Dystonic tremor doesn't respond to medication, which can help you differentiate it in one way. And the other thing is you wouldn't expect posturing, sort of an abnormal posture with essential tremor. We can use botulinum toxin in some people to help with both the tremor and the positioning, but not always. And it can be associated with genetic conditions, so we always take that into account. And cerebellar tremor, so you'll know from your cerebellar examination, you can get an intention tremor towards the end of a movement with cerebellar problems, and it's a feature when you're moving towards a target, but you would expect to see other cerebellar features like nystagmus, dysarthric speech, that sort of thing. So moving on to Parkinson's disease. So everybody thinks of Parkinson's disease when they think of tremor, but not everyone with Parkinson's disease has a tremor, so about a third don't. You must have slowness for it to be Parkinson's disease. If there's no slowness, if there's no bradykinesia, by definition it's not Parkinson's. The other features which are optional are your tremor, your rigidity, and your postural instability. So you look for that on your clinical examination. It's a progressive degenerative disorder. So you lose dopaminergic neurons that both produce and process dopamine. And over time you see both mobility and non-motor symptoms progressing, and cognitive decline is common. We diagnose Parkinson's overwhelmingly by clinical examination and taking a good history. Non-motor symptoms are important to take into account, your constipation, Anxiety, loss of sense of smell, anosmia, sleep features like REM behaviour disorder, these things are all important. And an experienced clinician is generally what you need. Very rarely we do a DAT scan, which is a functional dopamine transporter scan, and that's when maybe there's a lot of other conditions present or examination is particularly challenging. Probably we only do that in less than maybe 5 to 10% of patients. And the treatment is replacement of dopamine, as you'd expect. So that's levodopa, so synthetic dopamine. Sometimes we also use adjunct or other medications to try and boost the function of the dopamine that we put in. So we have COMT inhibitors like opicapone, which help the dopamine stick around longer, and MAO-B inhibitors like rasagiline do the same. Advanced therapies are just alternative ways to get the dopamine into you that doesn't have to go through the gut. So if your gut is affected by the Parkinson's, if you have constipation and slow gastric transit, that adds another level of complication to you getting the medication in. So we use things like apomorphine and phosphodopa medication, which is a sort of subcutaneous delivery that smooths things out, and also deep brain stimulation, which is neurosurgery. But that only works as well as the levodopa does. So if somebody doesn't respond at all to medication because they've progressed so far, these advanced therapies won't help there. And we don't have any way to slow the progression. There are different phases of Parkinson's disease. We sometimes describe it clinically. There's something called a Hone and Yahr scale. We can describe it in terms of how people respond to medication. So the honeymoon period, where people do really well after diagnosis, maintenance period, complex phase where things start to get tricky and you get cognitive problems and falls, and the palliative phase. The palliative phase is very hard to define, and I feel very strongly about that. But I think that we need to make people aware of how the disease progresses and help them prepare for it throughout the condition, and that can improve outcomes. So to summarise tremor, mostly when I see people in clinic with a presentation of tremor, I'm being asked, is this Parkinson's disease or not? And if I can tell people that it's not, that's often sufficient. Parkinson's disease diagnosis, therefore, can be delayed because a GP may not refer if somebody has symptoms of slowness or falls or cognitive problems if there is no tremor, because that doesn't trigger the thought, is this Parkinson's? And you need to have slowness of movement, bradykinesia, as a definition for Parkinson's disease, and a blended holistic approach is necessary.